All right, everybody, welcome to another video here at Whiteboard Medicine. We appreciate you checking it out. Today's topic is another topic within our vasopressors and inotrope series, and we're going to be talking about vasopressin, a very, very common vasopressor in the clinical arena. Particularly, we're going to dive into what is vasopressin, its mechanism of action, dosing and administration, some pharmacokinetics. We'll talk about clinical uses, evidence and guidelines, side effects, complications, comparing vasopressin to norepinephrine, some clinical tips and tricks, and lots more. For those of you new to the channel, always know that this study guide as well as practice questions is available on our Patreon page, linked in the description. We also have a newsletter and a podcast, all linked in the description. Now, if you're listening to this in podcast version, we also have a YouTube channel, again, linked in the description. So we appreciate you all. Hopefully lots of resources out there for you. We'd love for you to check some of those other ones out. No further ado, vasopressin. Friendly reminder, none of this is intended to be acted upon as medical advice. Full disclaimer at the end of this episode. What is vasopressin? Well, vasopressin is also known by two other names. Some of these may be more familiar, some of these may be less familiar. The first is arginine vasopressin, or AVP, and the second is antidiuretic hormone, or ADH. We'd assume more people would be familiar with ADH as part of many of the pathways we learn about in clinical training. Oh, let's allow that. And vasopressin is an endogenous hormone. It's a hormone that we all have circulating in our bodies, and it plays a major role in both fluid balance and vascular tone. This might start to explain, for those of us really enthralled by this video, and why vasopressin is used as a vasopressor, because it controls things like fluid balance and things like vascular tone, both things that can increase your blood pressure, your BP. So in critical care, in the ICU, or for patients who are critically ill, vasopressin is used as a second-line vasopressor. All right. This is often added to norepinephrine, brand name Levophed, in the treatment of vasodilatory shock, especially septic shock. And we're going to get into this a lot more as the video progresses. What is interesting about vasopressin and why we use it as a second-line vasopressor is that it's not catecholaminergic or not adrenergic, right? So when we think about vasopressors in general, we think about two kind of different larger categories, and there's multiple larger categories, but one are catecholaminergic, catecholamine. This is also known as adrenergic, okay? And these are a lot of the vasopressors that are first line, right? Things like norepinephrine, epinephrine, phenylephrine. All these are catecholaminergic or adrenergic vasopressors. Their mechanism of action uses catecholamines. But there's other types of vasopressors as well that use different pathways, different mechanisms. And vasopressin is one of those, right? It is ADH. It is an endogenous hormone involved in fluid balance and vascular tone. All right. It is not a catecholaminergic vasopressor, which means it is non-adrenergic. So it's helpful in patients who are already on catecholaminergic or adrenergic vasopressors like norepinephrine, because adding vasopressin uses a different pathway, a different mechanism. And it can be helpful sometimes in this catecholamine refractory hypotension that you can see, all right, as a second line. So diving deeper into the mechanism of action of vasopressin. So there's three different receptors vasopressin often acts on, okay? V1A, V2, and V1B. All right, V1A and V2 are probably the more important receptors when it comes to vasopressin's action as a vasopressor, right? V1A is in vascular smooth muscle. So why does this matter? Well, our blood vessels have all this smooth muscle around them, okay? And all this smooth muscle helps vasoconstrict those blood vessels, right? If that smooth muscle constricts, it causes the blood vessels to vasoconstrict. And this can sometimes increase blood pressure. This is how a lot of the catecholaminergic vasopressors work, right? Alpha-1 receptors causes vasoconstriction. Vasopressor, though, acts on V1A receptors on vascular smooth muscle, still leading to vasoconstriction, which increases your SVR, that stands for systemic vascular resistance, the resistance of your vasculature, and that increases your MAP, your mean arterial blood pressure, which is one of the goals of vasopressors, right? To increase the MAP, to increase the blood pressure. Vasopressin, though, has another mechanism of action as well that contributes to increasing the MAP, and that is the V2 receptor, which is on renal collecting ducts. All right, the collecting ducts are in the kidney nephron, and they control how much solute and electrolytes and water and urea go in and out, how much you excrete and urinate out versus how much you reabsorb and keep in the blood vessels. So the V2 receptor in the renal collecting ducts actually leads to water reabsorption. This can increase your intravascular volume, okay? And if you are in septic shock or hypovolemic shock, or you're in a shock state where increasing that vascular volume will be a benefit, this can help increase the blood pressure too. Now, this is a minor mechanism, right? You can still use vasopressin in shock states that do not require increases in intravascular volume. So you shouldn't shy away from vasopressin just because you think, oh, vasopressin is going to increase the intravascular volume. All right, it's a minor mechanism. You can still use vasopressin. The primary mechanism is this V1A receptor that leads to vasoconstriction. There is then a third, even more minor mechanism. That's the V1B receptor. This is in the pituitary gland, and it actually stimulates ACTH release. And ACTH, for those of you unfamiliar, is a hormone that downstream increases the secretion of cortisol or steroid hormone. Again, this is a minor role, but vasopressin does do that as well. So there's kind of these three separate mechanisms of action of vasopressin. One being the vascular smooth muscle causing vasoconstriction, 2 being in the renal collecting ducts causing water reabsorption, and 3 being in the pituitary stimulating ACTH release that can increase cortisol levels. So in shock states, vasopressin helps raise the mean arterial pressure by constricting peripheral blood vessels through that V1A receptor and augmenting intravascular volume via water retention via that V2 receptor. All right, so non-adrenergic, non-catecholaminergic pathways. How do we dose vasopressin? How do we administer it? Well, typically in the ICU, vasopressin is statically dosed. All right, so you put it at 0.03 or 0.04 units per minute fixed dose. It is not titratable. It can be titrated, but typically we order it as fixed dose. So the nurse isn't bedside increasing it or decreasing it depending on the blood pressure, right? We're not going from 0.03 to 0.04 to 0.05 to 0.06. We're leaving it at that fixed dose. So vasopressin is usually added as an adjunct to norepinephrine because the norepinephrine is titratable. This is the one you're going to titrate based on the blood pressure, whereas the vasopressin tends to be not titratable. Different hospitals use different fixed doses. 0.03 or 0.04 are both perfectly reasonable. All right. The higher the doses of vasopressin, there is somewhat of an increased risk of ischemia, either in the fingers, toes, or in the bowel as well. But 0.04 is still perfectly reasonable, but at that little bit of a higher dose, there is some increased risk of ischemia. So 0.03, 0.04 units per minute, fixed dose, not titratable. And you administer it through continuous IV infusion. Most often that's through a central line that is preferred. Some people can run vasopressin through a peripheral IV, a PIV, peripheral intravenous catheter, but this is kind of untested in a meaningful way. There's not a lot of studies on whether this is safe or not. So it's best done through a central line, and that's probably how it's most often administered to folks. Okay, pharmacokinetics. So the onset for vasopressin is actually a little bit interesting. The onset, it takes about 10 to 20 minutes before it kicks in. Certainly that's when it kind of gets to its peak. It might kick in faster than that, but you really do have to wait 10 to 20 minutes before you see the full effect of vasopressin, how much it's going to help or not help the blood pressure. And then the half-life is 10 to 20 minutes. So after you turn it off, it'll still stick around for another, 10, 20 plus minutes, right? So 5 half-lives is getting closer to an hour, which is when they say usually most drugs go on is in 5 half-lives. So 5 half-lives, T1/2 would represent half-life, is about an hour depending on what you choose from that 10 to 20 minutes. It is hepatically and renally metabolized. So if you have patients with renal failure or they're end-stage renal disease, or you have patients with a liver failure, they're not going to metabolize vasopressin as quickly, which means it might stick around longer, right? That half-life is going to be a lot longer. So you might turn the vasopressin off, but it might be circulating for more than that 60 minutes if you have a renal failure or liver failure. And it's eliminated either urinary or hepatic, right? Kind of same mechanism. So same thing holds, renal or liver failure, it's going to stick around a lot longer. Clinical uses. The most common clinical use is most often septic shock, when you're in shock from a severe infection. And in that case, it's that second line vasopressor. So you start norepinephrine, and if the norepinephrine is not working, you're going up and up and up on your norepinephrine doses, that's when you start vasopressin. Guidelines out there, if we were to use the Surviving Sepsis Campaign guidelines, they stay to start vasopressin when you're between 0.25 and 0.5 micrograms per kilogram per minute of norepinephrine, norepinephrine. This is just expert consensus. There's no magic here. There's actually some complex evidence that could in the future support starting vasopressin earlier, but as it stands right now, at least the Surviving Sepsis Campaign suggests starting the vasopressin after you are on more than 0.25 to 0.5 micrograms per kilogram per minute. If you don't do weight-based norepinephrine dosing, this for, your 70 kilo person is going to be something like, 20 micrograms ish per minute, all right, of norepinephrine. And that's when you usually start vasopressin, either at the 0.03 or 0.04 fixed dose. You can also use it in vasodilatory shock, all right, that post-cardiac surgery patient, the spinal or neurogenic shock patient. Cardiac arrest, it was previously actually an ACLS, advanced cardiac life support. This is a big algorithm commonly used to treat patients with cardiac arrest, but it was removed in the 2020 guidelines, so it's no longer recommended in cardiac arrest. All right, esophageal variceal bleeding. Some people use it off-label to vasoconstrict the splanchnic blood vessels. Those are the blood vessels in kind of the gut that can be involved in variceal bleeding. This isn't something commonly done, but it is something that can be done. And it's via that V1 receptor, causing that smooth muscle vasoconstriction of those splanchnic blood vessels in the gut. And then diabetes insipidus, okay? So diabetes insipidus, or DI, this is not being used as a vasopressor here, but you can, via the V2 effect, right, if we go back up to receptors, V2 was one of the receptors used, and that's caused water or reabsorption, right? So this essentially helps you in patients with diabetes insipidus reabsorb water so that you don't have as much hypernatremia. So outside the confines of this discussion, but diabetes insipidus is where you're urinating out a ton of water, so you have increased water excretion. That leads to your sodium being high. So the V2 effect with vasopressin just helps you hold on to that water so that you have less water excretion to help you normalize your sodium. But for the sake of critical care stuff and vasopressors, these two are the biggest ones, septic shock and vasodilatory shock. If we were to get into some of the more complexities of this, sometimes we like vasopressin a little bit more in patients with right heart failure. Right heart failure patients are pumping blood against the lungs, right? The pulmonary vascular resistance, the PVR, is the afterload of the right heart. This is complex. If this is too complex, feel free to blank out during this part. But catecholaminergic vasopressors like norepinephrine cause vasoconstriction of those pulmonary blood vessels, whereas vasopressin is thought to not cause as much vasoconstriction of the pulmonary blood vessels, so it won't increase the right heart afterload. So in patients with right heart failure, where you don't want the right heart to kind of have to pump against more resistance in the lungs, vasopressin is sometimes a nicer drug than the catecholaminergic vasopressors like norepinephrine. But that's a more complex topic. If that's something you're interested in, we're happy to put a whole video out on it. Let us know. I'm happy to do that. Evidence and guidelines. There is a trial that's worth knowing when it comes to vasopressin. It's called the VAST trial. It was published in the New England Journal of Medicine back in 2008. And it looked at norepinephrine versus norepinephrine plus vasopressin in septic shock. And there's actually no mortality difference between the two groups. So adding vasopressin to norepinephrine did not improve mortality versus norepinephrine alone. But in less severe shock states, vasopressin may be reduced mortality. Now, this is a loaded statement. We're actually going to cross it out, but it's worth knowing. It was not powered for this, but this is what we were implying. We're maybe starting vasopressin earlier rather than waiting until you get to that 0.25 to 0.50 micrograms per kilogram per minute of norepinephrine. Maybe starting it earlier, the vasopressin earlier would be better, but we don't know that. In the vasopressin group, there were lower rates of arrhythmias. It did decrease norepinephrine doses being used. So it seems like adding vasopressin, most likely at these higher doses, does not improve mortality, but it might decrease the number of arrhythmias a patient's going to have. It also might decrease the amount of norepinephrine they need. And maybe if you start the vasopressin earlier, maybe, we do not know this, maybe that might have an effect on mortality, but that will require additional studies. As we mentioned, the Surviving Sepsis campaign in 2021 did recommend adding vasopressin to norepinephrine when MAP goals are not met, and that norepinephrine dose when it suggests starting is that 0.25 to 0.5. We said this a bunch, micrograms per kilogram per minute, which is like around 20 micrograms per minute of norepinephrine, okay? That's when the Surviving Sepsis campaign at least suggests starting vasopressin. 0.03 is a dose often used, or 0.04 is the other dose used, but at the higher dose, there's a little bit increased risk of ischemia of the digits in the gut. ATHOS 3 is a trial that looked at angiotensin 2, which is a different vasopressor that we're going to talk about, and it compared it to different vasopressors. One of those was vasopressin. This is probably not that helpful. We don't think it probably contributes too much, so we're going to cross it out. Okay, what else? Side effects and complications of vasopressin. As we already implied, vasopressin can increase ischemia of everything, the digits and the gut being two of those things. So increased risk of mesenteric ischemia, increased risk of digital ischemia. All right, it can cause hyponatremia. Now, why is that if you think about it for a second? Well, the V2 receptor, we said, increases water reabsorption in the kidney. So if you're increasing free water reabsorption, that can drop your sodium. So it can lead to hyponatremia. Some patients, this is very rare, but it can cause coronary vasoconstriction. That can lead to cardiac ischemia, but that's not something we often think much about. And then if extravasates, so if you use a peripheral IV and it gets out of that peripheral IV into the skin and extravasates, it can cause tissue necrosis. Less common than norepinephrine, maybe, although we might even cross that one out as a maybe. And then a central line is preferred for vasopressin. So just a comparison, norepinephrine compared to vasopressin are two kind of first line agents we often use for vasopressors. Norepinephrine is adrenergic, right? I said that a couple times. It's a catecholamin-ergic vasopressor, just like epinephrine and phenylephrine. Whereas vasopressin is a non-adrenergic, right? It does not act at catecholamine receptors. Vasopressin acts at V1, V1A, and V2. Norepinephrine acts at alpha 1 and beta 1, which we'll talk more about in the norepinephrine video. Titration, this is fixed dose. Vasopressin is not titrated, whereas norepinephrine is titrated to a MAP goal most commonly. The arrhythmia risk is lower for vasopressin because it is not catecholaminergic, so it does not affect some of those receptors in the heart, like beta 1, that can increase the risk for arrhythmias. So it has less effect on the heart for arrhythmias. Whereas norepinephrine and all the catecholaminergic vasopressors that have cardiac receptor effects, like the beta receptors, do increase risk for arrhythmias. People say that vasopressin works better when a patient is acidemic as compared to its catecholaminergic vasopressors like norepinephrine. How much of that is clinically meaningful is tough to say, but theoretically vasopressin maintains its effect even in acidemic environments compared to a vasopressor like norepinephrine, which theoretically does not work as well in acidemic environments. And then vasopressin is second to line in septic shock, norepinephrine is first line in septic shock. So in summary, vasopressin is an endogenous hormone. It works on the V1 receptor primarily, which causes vasoconstriction. It also works a little bit on V2, which causes free water reabsorption. The usual dose is 0.03 units per minute fixed. Some institutions use 0.04 units per minute. It's a second-to-line vasopressor in septic shock as its primary use, best combined with norepinephrine. High doses can cause ischemic complications, both mesenteric ischemia in the gut and digital ischemia. And then there is some evidence, particularly the VAS trial, that has led to vasopressin being included in the surviving sepsis guidelines as an add-on to norepinephrine. If a patient's on norepinephrine at greater than 0.25 to 0.5 micrograms per kilogram per minute, the surviving sepsis campaign would suggest adding on vasopressin fixed dose. So just a little tip, when norepinephrine alone is not reaching the target map in a patient in septic shock, add vasopressin. Consider adding it even a little earlier, but especially as norepinephrine is exceeding about 15 micrograms per minute, which is right around that 0.25 to 0.5 micrograms per kilogram per minute dose. That's all we have for you today on vasopressin. This is kind of an introductory lecture, one of many in our vasopressor inotrope series. Subscribe, hit the bell button, follow along, check out our other videos. If you want this study guide or practice questions, check out our Patreon page. Let us know what you think, and in any case, stay well, keep learning, and we'll hope to see you next time. Hey everybody, and welcome to Whiteboard Medicine. We appreciate you checking out the video. Here at Whiteboard Medicine, our goal is to create medical education content for all types of interested learners. That includes videos, practice questions, study resources, and much more. We would love for you to join our community by subscribing, hit that bell button. We're also working to build a high-yield Patreon page. It's going to be full of practice questions, video outlines, notes, commercial-free content, and much more.
None of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety before moving on.